I don't have any financial disclosures, but I do play a leadership role in the AIUM and the Perinatal Quality Foundation, so I have an implicit bias towards the utility of ultrasound. Our objectives this morning are to recognize the available practice parameters that we have for evaluating the fetus in the first trimester, and we're going to really focus briefly on the AIUM standard practice parameter, the ISWOG, the International Society of Ultrasound and Obstetrics and Gynecology practice parameter, and the AIUM detailed parameter, which Dr. Abu Hamid mentioned, which is in development. There is a German practice parameter that, because of time, we're not going to be able to look at in detail. What I'd like you to accomplish at the end of this talk is I want you to be able to understand the importance of following a standardized anatomic protocol. Many people I talk to will say, well, we look as much as we can. That's not good enough. You really have to have a list of anatomic structures that you're going to scrabble to find, and based on your training, you may want to look for other things. We'll talk about the required components, specifically of the detailed AIUM practice parameter, and you'll be able to appreciate some of the more extended views that we can find. Now, why is a protocol important? Karim et al., in a systematic review and meta-analysis of first trimester anomaly detection by ultrasound, found that we can actually diagnose between 30 and 60% of all abnormalities, depending on whether you're low risk or high risk, and that the thing that was most important in improving our pooled detection rate was actually following a standardized protocol. So the first practice parameters, the collaborative AIUM standard practice parameter, it was published in 2018, and there is a portion that is dedicated to the first trimester. We also now have a detailed practice parameter that involves the fetal anatomic assessment as well as placental assessment. But I have to tell you, this is preliminary. It has not been published, but we're really close to getting it done. So what do you need to know for the standard practice parameter? This is as low as you can go. You can't go any lower than this. In the first trimester, you need to demonstrate the calvarium. You have to demonstrate the cord insertion site into the fetus, and you have to look at the limbs. Doesn't say how much of them you have to look at, but you have to look at them. And of course, you have to look at the nuchal region. You don't have to do a specific nuchal translucency measurement, but you have to subjectively assess it for the presence of cystic hygromas. So here are the things that you absolutely have to see. You have to see the calvarium. You have to see the cord insertion into the fetus. You have to look at the nuchal translucency area, and you have to look at the extremities. Now, ISWOG has taken this quite a bit further. They have the required components that AIUM has, but in addition, you have to look at other things. You have to look at the midline falx and the choroid plexes. You have to look at the lung fields. Are they symmetrical? Do you have any effusions? You have to look at the stomach. Make sure that it's in the left upper quadrant. You have to look at the limbs. You have to look at all 4 limbs, and you have to see 3 segments on each of them. And lastly, you have to look at the placenta's echotexture. Now, there are other things you can do if clinically indicated, but those are the basics. For the AIUM practice parameter for the detailed fetal anatomic assessment, the first thing to note is that we chose to start it at 12 weeks gestation to 13 plus 6. And again, this is preliminary. This is an indication-based ultrasound, meaning it's much like the 76811 or the detailed ultrasound. There has to be some kind of indication that would provide the opportunity to find a structural abnormality that is potentially detectable in the first trimester by imaging. And it's meant to be done by providers who have extensive training in fetal imaging. So you have to qualify to do the 76811 or detailed scan in the second trimester, but you're also going to need additional CMEs and volumetric experience for first trimester anatomic imaging. Now, we know back from 20 years ago that our colleagues at the Royal Free Hospital looked at how often we saw normal anatomic structures at the end of the first trimester, and you can see that very often between 12 and 14 weeks, we can see normal things, brain, spine, face, and etc. The ability to perform a complete anatomic scan obviously increases between 11 and 13 weeks, and our need to do transvaginal sonography to complete that scan decreases with advancing gestational age. That's shown in the pink there. So the sweet spot is about 13 weeks gestation. This has been echoed by Rossi et al. In a publication in OBGYN in 2013 when they did a systematic review of over 78,000 fetuses in the first trimester. And again, the sweet spot for your first trimester anatomic scan is 13 weeks. The method of imaging is really quite variable, and the studies are incredibly heterogeneous. But if you use transabdominal scanning alone, you pick up about 50% of anomalies. Transvaginal, about 34%. And if you do a combination, your detection rate is higher. So in our first trimester anatomic practice parameter, we've decided by expert consensus and looking at practicality of performing the study that you should start with a transabdominal approach and complementary transvaginal imaging is needed. If you don't see a structure or if you're otherwise worried about the fetus, you should be liberal in pulling out your transvaginal scan, but it's not mandatory. So to start off, the first thing that people are always concerned with is you have to make sure that you're compliant with ALARA, the as low as reasonably achievable principle. And to do that, you have to monitor your output display standard, which is somewhere on your monitor, and you should be following and looking for a thermal index for bone, because obviously bone ossification has occurred by this stage, and you want your numeric threshold to be 0.7 or less. Your heartbeat should be documented by M-mode or video clip, and never use spectral Doppler to hear the heartbeat, even if the mom asks you. You need to evaluate the head, and I've tried to list the components in white as what are currently required in this new practice parameter, and those in blue as if medically indicated. Obviously, because it's to be done by providers with extensive training, this practice parameter is more important than a list of items. The list is the basic minimum, and then if you have a patient with an issue, then you have to go beyond that minimum. So the first level that you look at the head at is the transventricular plane, and you want to make sure that you see the calvarium, that it's oval, that there are no bulges, that it's properly ossified. You want to identify the falx cerebri as an echogenic line that's going to divide your cerebral hemispheres into symmetrical halves. You need to look at the choroid plexes, and these are heterogenic structures that fill the majority of the lateral ventricles. A lot of people have called these looking like butterflies. Maybe yes, maybe no, I'm not sure. You also have to look at the CSF that surrounds the choroid plexes, and this is mostly in the front of the head, but some in the rear. And then if you're looking specifically for the composition of the brain, you can look at the brain, which is seen most clearly in the anterior portion of the head. The second level is your transthalamic level. You look at the same things you did in your transventricular plane, but you also want to see two discrete thalami. And just for your anatomic sort of education, you want to make sure you see the cerebral peduncles, although those are not required. And in between the cerebral peduncles is your aqueduct of Sylvius. One of the new signs potentially for spina bifida is a posteriorly displaced aqueduct of Sylvius, so you want to make sure that your aqueduct is not against your occipital bone. Angling more posteriorly, which is in the second trimester called your transthalamic, your transcerebellar view, but the cerebellum isn't really formed at this stage. You want to look at the posterior fossa, you want to look at the fourth ventricle, you want to look at the choroid plexus of the fourth ventricle, and you want to look at the cisterna magna. Now, you're all familiar with the median or mid-sagittal view of the brain. You want to look at the thalami, the midbrain, and the brainstem, and you want to make sure that has a normal configuration. You don't want it to appear kinked or otherwise funny shape. In addition, you want to look at the intracranial lucency, which is another name for the fourth ventricle, the cisterna magna, and the choroid plexus between the two. Now, another way to look at this is to look for three echolucencies in the brain. You can see the brainstem, the IT or fourth ventricle, and the cisterna magna. At the same time, you're going to look at your fetal profile. You're going to make sure that the profile is rounded, it's not too protuberant, and it's not too flat. You're going to look at the nasal contour and the nasal bone, which, as you all probably are very familiar with, looks at as equal sign, with the nasal bone being more echogenic than the skin edge. You want to look down the face, make sure that the contour of the lips are smooth. You want to look at the maxilla, make sure that there are no holes in it and it's properly ossified. And you also want to look at the mandible. Now, another way to look at the face is in an axial or coronal view, and this is your opportunity to look at the orbits and the lenses. You can look at the nasal bone in your retronasal angle view. You can see the paired nasal bones, the frontal process of the maxilla, and the anterior palate. And then you look down and you see the bones of the mandible with the normal mandibular gap. A gap in the mandible is a normal thing. And if you look at it during live scanning, you can see it just takes a very little bit of movement to see all those structures because the fetus is relatively small. Now, if you have a family history of abnormalities, maybe cataracts, maybe other things, you're going to want to look at the lenses. You're going to want to look at the contour of the lip or the position and appearance of the ears, but these are really if clinically indicated. The nuchal translucency is not absolutely required to be measured, but if it looks abnormal in any way, you should do a precise measurement because it'll help triage your risk of other congenital abnormalities. You want to look at the neck, look for your jugular lymphatic sacs. You'll also be looking for cystic hygroma. Now, I assume all of you here are actually credentialed in nuchal translucency. Obviously, if you're using that for risk assessment, you still have to be a credentialed provider by one of the two organizations listed. So then we look at the thorax and abdomen, and we want to look at the situs. You should take an axial sweep. The stomach should be in the left upper quadrant, and the heart points to the left. Look at a sagittal view. You can see that the diaphragm is going to separate the more echogenic lungs from the more hypoechoic liver. And on coronal imaging, you can see both lungs there separated by the diaphragm from the abdominal cavity. We look at the thorax and make sure that the lungs are symmetrical and there are no effusions, and that the ribs are of appropriate length, echogenicity, and architecture. And you can turn yourself coronal to make sure that the ribs are coming off at the correct angle. When we look at the heart, we look at the four-chamber view of the heart, and we looked at it initially subjectively. You don't have to make any measurements if it looks fine. The heart has to be in the left side of the chest with a left axis of 45 degrees. You want to make sure that if it looks abnormal, that you can do a cardiac axis measurement, and Dr. Sinkovskaya will be talking to you more about this technique. Basically, you line the spine up at 6 o'clock and bisect the chest, get another line along the long axis of the heart and measure it. Color is incredibly important because it'll help you distinguish that the two ventricles are symmetrical. You will see diastolic filling. You will see potentially tricuspid, you see regurgitation in the valves, and this is just another example of how to measure that. So we want to make sure that the left and right cardiac ventricles are basically the same size. You want to be able to identify the atrioventricular valves and the atria and watch during real-time scanning the way the movement of the heart occurs. The four-chamber view with color, as I said, was really important because that helps you delineate, especially in the younger babies, what you're looking at exactly. And then you're going to be required to look at the three-vessel trachea view with color because you're going to be assessing the differences in size of the vessels as well as the direction of flow. Now these are two little clips just to show you how relatively straightforward this is to see. Here you can see a clip right there That was weird, wasn't it? Did you see that go away? I don't know what that was. But you can see a very tiny sweep because you're talking about really small spaces, how tiny little changes will let you see all this anatomy. Now, when we look for cardiac malformations, most are identified based on these views. 4, you want to know the situs, you want to look at your 4-chamber view, your 4-chamber with color, and your 3-vessel trachea view. If you have any questions, then you do further views. You can do extended cardiac views, looking at your outflow tracts longitudinally, and color flow to look at direction. If you are of the desire to look at your tricuspid flow or your flow in the ductus venosus, you can do that as well, as long as you're a credentialed provider. The one thing I want to warn you, in order to make slides for this presentation, because we don't often do this, I turned on my color and I noticed, look at that. So my responsibility to Alara is, oh, my preset was not right, and I have to change it. So again, this is an example of how you have to watch your presets. So we want to look at the abdomen and 3 axial planes, upper, mid, and lower. And you can see the sagittal and axial sweep through the abdomen. You want to note that the stomach is in the left upper quadrant, and you want to see the portal vein, if possible, coursing away from the stomach. Sometimes it's difficult to see, especially at 12 weeks. If you have a particular interest, you throw on your color, and it's easy to demonstrate. We talked about demonstrating the umbilical cord insertion side into the fetus. My personal favorite view is the axial scan, but you'll hear Dr. Abu Hamad and Dr. Abu Rustam talk about the importance of the mid-sagittal scan, so also be aware to look at it in that direction, and here you can also see the bladder in that mid-sagittal view. So you can see the kidneys also in the axial scan. I think they're harder to see in this particular position, and you can mistake the adrenals for the kidneys. So make sure that you look at them sagittally as well, or in my experience, coronally is the best way to see them because you can really see them pretty clearly outlined. If for some reason you can't see them, throw on your color. We're going to look at the bladder axially, and you can see the fluid-filled structure, and you want to look at your umbilical arteries. You have to be careful, and Alfred will talk to you about optimization of your color and positions because you can inadvertently think you might have a single umbilical artery when you don't. We need to look at all 4 limbs. Each has to have 3 segments, much like the ISWA guidelines, and you have to identify 3 bones in each of the segments, or in each of the limbs. And here you can see your humerus, radius, and ulna, and you can also see your little hand. If clinically indicated, you need to look at the fingers. Maybe somebody has a family history of polydactyly. Maybe they have funny-looking cystic kidneys and a history of Meckel-Gruber, and you need to look at the hands. If there's a clinical indication, look at fingers and toes. And you could look at the spine in all 3 dimensions like you do in the second trimester, making sure that your vertebrae are aligned properly and that you look at the skin edge. Well, what about biometry? We all know that biometry is really important for dating, but it's also important for anomaly detection. You can see the little fetus on the right here, whose head is very big compared to his body. This is characteristic of digyne triploidy. This is a normal fetus, and this fetus has very stubby limbs, so it'll help you make the determination of a skeletal dysplasia. The practice parameter is very proscriptive on how to measure the crown rump length, and for time I'm not going to go into that, but when you read it, you will want to really follow these parameters, and you're going to report the mean of 3 acceptable discrete measurements. The biparietal diameter and head circumference has been a little bit contentious whether it should be required or if clinically indicated. Currently it's sitting in the clinically if indicated column. It's measured the same way you would in the second trimester, but be very careful because in the first trimester, the nomograms for evaluating size are a little bit different. The upper caliper is on the outside of the calvarium, like you always do, but the bottom caliper can be in the inside of the calvarium or it can be on the outside. So make sure you know what the nomogram you're using calls for. Head circumference is done in the same way that it is in the second trimester. Abdominal circumference is also if clinically indicated, although many practices do it routinely. And again, it's very similar to your second trimester metrics. Femoral length is really not very accurate for dating. It should be done if you're suspicious of any kind of skeletal anomaly. Here you can see a short bowed femur in a fetus who had lethal skeletal dysplasia. The current new practice parameter is also going to require you to look at the placenta. You're going to have to look at echotexture, masses, and heterogeneity of the placenta. Typically, we don't report placental location unless you're at risk for placenta accreta spectrum. One of the big areas of this practice parameter that's really important is that you will be required to do a detailed placental evaluation in a patient who's at risk for placenta accreta spectrum, perhaps a prior cesarean scar pregnancy in the cesarean scar pregnancy in this index pregnancy, or cesarean deliveries. So you're going to have to look at the location of the placenta, specifically in relation to the lower uterine segment or previous hysterotomy. You will be asked to evaluate the placenta with color Doppler. You'll want to look for myometrial thinning, the bladder wall interface, and uterovesical vascularity. And a lot of these findings I'll be talking to you in my last talk, I believe on Saturday morning. Nobody should leave this detailed type of ultrasound without having amnionicity and chorionicity expertly detected. You're all very familiar with how to do this. You also have to look at the uterus to look for structures like fibroids. The number, location, and size of any significant fibroids needs to be reported. You have to look for any potential Müllerian duct anomalies and report them, or synechia. Here's a fetus on the right who had multiple DNCs, and you can see a synechia going right through the sac in the first trimester. You're also going to have to look at the ovaries, and you're going to have to be able to know what is a normal corpus luteum. I think that's pretty straightforward, but you're going to be expected to be able to identify very basic ovarian masses. You're going to expect not to call these complex. You're going to be wanting to know that this is a characteristic dermoid, this is a characteristic endometrioma, and you really are going to be want to be up on what ovarian torsion looks like. So as I said, this is a preliminary look at our practice parameter. We are very close to publishing it. It has gone through initial review with a big collaborative committee that has included SMFM, ACOG, ACOOG, SDMS, PQF, ACR, and SRU. Dr. Abu Hamad has been very instrumental in trying to get a group together to obtain a code for this so that you'll be reimbursed for all this hard work, because it's not an easy study to do. And I'd like to thank a lot of the faculty who are here. Alfred and Dr. Platt are on the collaborative committee, Alfred representing SMFM and Dr. Platt representing PQF, and myself, as Dr. Abu Ahmad said. And then I have to thank Dr. Sinkovskaya and Dr. Abu Rustum, who have served as expert reviewers. All our comments are in. We are probably having one last meeting, and I expect you'll see this probably by September, October, and it'll be formalized by the AIUM Board of Governors meeting in 2019. So I hope that you embrace this once it comes out and really practice this systematic evaluation of the fetus so that we can optimize our detection rate of anomalies. Thank you.